Hello everyone, my name is Stephanie Poland and I'm here today to talk to you about the use of early progressive mobility in the neurotrauma patient. I'm a registered nurse in a neurotrauma progressive care unit at a level 1 center in Southwest Virginia. I am our unit preceptor. I was a travel nurse for 3 years while I obtained my Bachelor's of Science in Nursing. I am currently in the DFNP track here at USA, and I love anything to do with family, mountains, and downhill skiing. And I chose early progressive mobility because I work in a patient population that is extremely complex, and it can sometimes be very hard to mobilize these patients, but it's so important to their long-term outcomes. So the outline today is going to be, we're going to look at the significance of the practice problem, look at my PICO question, see my search strategies, go over the evidence I found, see what change model I decided on, go over database evaluation, my process for dissemination, my practice recommendations, and then the conclusion. So the significance of the practice problem. So there are several barriers to early progressive mobility, and one of those is that many think that it requires a designated team. Another thing would be staffing ratios, making sure that you have enough people to ambulate these patients safely. Patients and families often don't understand the importance of moving early, even if you are very, very injured. Your staff's ability to identify who is appropriate to be mobilized and who is not. And then the confidence that your staff has to mobilize these patients. In consideration, again, the confidence of our staff and the knowledge. For trauma patients, they're complex. And also, if we implement it too early, we can cause increased cerebral bleeding from hypertension. And if we're not adherent to certain weight-bearing restrictions, we can cause further injury. My PICO question says, does early progressive mobility orders in the adult neurotrauma patient lead to a decreased length of stay by 2 days compared to those with standard activity orders as tolerated? Every patient that comes onto our neurotrauma unit gets activity orders, activity as tolerated. So I'm wondering if we had a protocol that said every patient moves every day, if we would see a decreased length of stay, because often our patients either cannot ambulate on their own or refuse to ambulate. So that is why I'm addressing this question today. So my search strategies, I used 3 different databases: EBSCOhost, PubMed, Google Scholar, and my keywords were early ambulation, progressive mobility, ambulation in the ICU, ambulation protocols, and neurotrauma. And that's kind of where I ran into a little bit of difficulty. There is not a lot of information on this topic in this particular patient population. So I ended up having to divide neuro and trauma up to get enough research articles, but I was able to meet my 10, which you can see in my Prisma picture that I have included. And the data parameters I went with were 2010 to 2019. And my reason behind that is I really wanted to see the progression of early progressive mobility since I have entered the nursing field. So my evidence for change, one of the biggest things they found was that it lowers the need for the length of mechanical ventilation. And by doing that, they were able to decrease the incidence of hospital-acquired pneumonia, or VAP. Also, implementation that started in the ICU, they saw earlier independent ambulation, as well as these patients returning home with either home health or without any need for further assistance because they'd returned to baseline versus having to enter a rehab facility for any amount of time. There was a lowered incidence of hospital-acquired deep vein thrombosis and pressure ulcers. HAPUs affect 2.5 million patients a year. They cause 9.1 to 11.6 billion in extra healthcare costs and can increase one's hospital stay by upwards of $43,000. For your deep vein thrombosis, that's going to affect 500,000 patients a year and increase healthcare costs by greater than $10 billion. Early progressive mobility showed a significant decrease in anxiety and depression and hopelessness in these patients due to the feelings of powerlessness from just so many procedures or the length of stay that they had to have in the hospital or lack of voice in their care. So this allowed them to feel like they were part of the team and in the end lowered their hostility toward their caregivers. Early mobility showed that when it started in the ICU, it's actually the level that that patient reaches in the ICU of mobility is a very good predictor of how that patient is going to do long-term past their hospital stay. Their decreased length of ICU, PCU, and overall hospital stay was shown to decrease by about 3.5 days in a meta-analysis done by both Klein, Benham, Mulkey, Albert, and then Lee, Zhang, Wang, and Nguyen. These are very similar studies, but both showed that early progressive mobility made a significant difference in these patients. And then last, it was determined to be safe and feasible with dedicated personnel. These patients can't ambulate on their own. You don't have to be trained, but they do have to be trained specifically for this, but they do have to be dedicated to getting these patients moving. So the change process I chose was Advancing Research and Clinical Practice Through Close Collaboration, otherwise known as ARC. It is a 5-step process. It assesses culture and readiness for system-wide implementation. So you're determining where everyone stands as far as bringing in a change, identifying our organizational strengths and barriers, such as lack of education, staffing ratios, and then patient willingness, identifying mentors, which would be like your charge nurses, your unit managers, your clinical team leads, people that are going to step in and really get behind this project and be passionate about it and understand the importance of it. Then you implement your evidence into practice and then evaluating your outcomes to see how your change made a difference in your patient population. I chose this model because it's closely in line with the facility that I currently work for. They are very dedicated to evidence-based practice, but they want to do it in a way that their staff feels very supported so that the likelihood of the change staying in place is very high. So database evaluation. I chose to do the McNamara's test because it evaluates the outcome of 2 different approaches to treatment. And remember, we're looking at standard activity as tolerated orders versus early progressive ambulation. I determined that my data is going to be quantitative, numerical, and interval. The collection is going to be done through the electronic medical record because through that we'll actually be putting in a section so that there can be documentation on the patient met the criteria, this is the mobility that they had today, and then we will look at length of stay following discharge. Data analysis will be done using a paired t-test, the SPSS. I would like to implement a bar chart for the visualization of the difference that we made in patient length of stay. And then finally, Microsoft Excel spreadsheet we can use to look at length of stay again, also how many patients it was implemented daily per protocol, and then also for those that had a longer stay, we can see, we can look at gender, we can look at injury, we can look at comorbidities, things like that. So dissemination. Institutional-wise, I plan to present this to the Vice President and Chief Nursing Officer, the Director of critical care, the vice president of surgery, and the director of neurosurgery, because those are the services that are closely working with this patient population and will be assisting in this project. Identifying and educating unit leaders, we talked about that, such as our CTLs, our charge nurses, our managers, our senior managers. These are the people that are going to be helping to lead the project. Education will be done through drive-bys to unit staff. This is their preferred method for education and can be less intimidating for them if they have questions. We will be implementing it into daily practice by identifying patients who meet the appropriateness in nursing shift huddle, as well as during unit interdisciplinary rounds that happen at 10 a.m. each day. Locally, I would like to present it to the American Association of Critical Care Nurses chapter, because though early progressive mobility has been shown to improve patient outcomes, it is still kind of wary in critical care settings. Nationally, the Society of Critical Care Medicine, again, getting this process moving in the critical care setting, and the fact that all aspects of critical care are involved and can help make a change nationally. The Society of Trauma Nurses understands the importance of ambulation in the trauma patient and are working really hard to figure out ways to decrease the barriers in these patients. And then the Critical Care of Nurse Journal, I like it because it is very informative, but it's also to the point without being overwhelming. So practice recommendations. Know your patient. Understand their injuries, understand their barriers, and know ways to improve. There will be an evidence protocol, and it is there to guide us so that both our staff and our patients are safe. Utilize it. Again, education is key to change. If our patients aren't educated, they're not going to be willing to move, and if our staff isn't properly educated, they are not going to be willing to ambulate these patients or be reluctant to ambulation. And be available for those that are going to be mentors, and such as myself and leading this project. Be available to answer questions, be available to assist with ambulation and moving these patients, and then utilize opportunities within our field to educate, whether it is on our unit, different units, or different healthcare organizations that we're involved in. The picture behind this says muscle, movement, and mobility, and that's really our goal, to strengthen those muscles so that we can move, so that these patients can get back to mobilizing at their baseline. In conclusion, early progressive mobility lowers the need for invasive interventions. It lowers the need for lowers the incidence of hospital-acquired complications. It improves patient psychological health, which leads to a decreased length of stay, and it also helps patients to return home at baseline function earlier. And last but not least, it does require dedication and commitment by your staff for them to get patients up and moving. This is doable. And we have to remember that our patients are our number one priority. And sometimes change is hard, but it's for the best. The last two slides are my references. Thank you so much for listening.